All right, so we're just going to be covering a couple like things put together by HIV, DIC, and fluids and electrolytes. So, these are just some medications, the antibiotics and antifungals that will be on your final OSCE. So we have ampicillin or totacillin. It's in the penicillin family. So because of like how penicillins have been used for a really long time, lots of people have developed allergies to them. And so you just always want to check, obviously, for allergies to begin with. And I think ending with psyllin is in the penicillin family and it's to be avoided. So pretty much with all antibiotics, you can just assume that there's going to be some like GI dysfunction as a side effect, like constipation, diarrhea. Anyways, but the mycins, like so, it's gentamicin, vancomycin, things like that. The other side effect or adverse reaction is nephrotoxicity and ototoxicity. So if they start to have like ringing in the ears or tinnitus, like it could be having some like ototoxic effects. And so all the mycin families you want to infuse slowly, obviously referring to clinical pharmacology for how fast to deliver these medications. So I've starred like the important ones, the ones that come up a lot. So cefazolin or Ancef um, is one that's pretty common, especially like given before surgeries to prevent infection. Ceftriaxone or Cephin is a cephalosporin. Um, okay, so another interesting side effect too is like the floxacin, so like Cipro and like levofloxacin can cause tendon rupture. So that's like one of like the key characteristics of the like Cipro and levofloxacin. Um, let's see, metronidazole flagyl is another common one. And then piperacillin tazobactam, as you guys know now, Zosyn from your advanced skill OSCE. Um, that's just another common one that they use. So, yep, just make sure to go over these and understand them. 'Cause obviously, they're pretty common in the healthcare world. So, okay. So, going over infections, there's a couple definitions to know. So, one is emerging infection. So, basically, like the incidence of this infection is increased over the past 20 years. So, examples like SARS, COVID, Zika, Ebola, it's things that are just rising in prevalence. As far as the geriatric population, they're 2 to 3 times more likely to get an infection. And so like UTIs are super common in the elderly population. So there's an important thing to remember with the geriatric population is that fever is not always a great indicator of infection. And a lot of times it's because they're taking like daily ibuprofen, daily acetaminophen, NSAIDs, aspirin. Um, and so just like for other reasons, for pain or for swelling or arthritis. And so it causes a blunted febrile effect. And so like their fever is controlled by the medication. So it's not always the best indicator, but often with geriatric patients, confusion or change of level of consciousness is one of the first indicators. And especially with like UTIs or something, that confusion is going to be the first sign. Um, and then, like, if they have crackles, you're going to want to get an x-ray or have the doctor order an x-ray to look for infiltrates and just like what's going on in the lungs. And so crackles require further exploration of what's going on. HAI or healthcare acquired infection. Just you want to remember your precautions like contact, droplet, and airborne. I won't go over these since you've learned them in the past, but making sure like you know what diseases constitute contact, droplet, airborne, and like when you would, like if it's a contact, but you're going to be doing dressing change, like you want to make sure you wear droplet precautions just in case something splashes. Um, Something important to remember though is if you have somebody in triage with like a suspected serious droplet illness, like meningitis, you want to make sure like your first action is to separate them from everybody else. So isolate them. Okay. They're like your priority patient. All right. Remembering the PPE you would use for each precaution, as well as the order in which you put it on and take it off. But as far as standard precautions go, remember the importance of hand hygiene. It seems easy, but it is also commonly the answer to questions like how do you prevent transmission of diseases? It's hand hygiene. Okay. And then we have drug resistant infections like MRSA. Um, you want, like, you can prevent drug resistant strains by, like, the big problem was that antibiotics are being overprescribed in the past and prescribed for things that weren't necessarily like a big problem. And also people not receiving like proper education as far as antibiotics and not finishing their full dose. And so to prevent further drug resistant strains, antibiotics only when necessary and educate well so that they finish their dose and so that they know what happens in their body if they don't finish their antibiotics. Okay, this is just a reminder of the order to don and doff PPE. Okay. All right, HIV and AIDS. And so this is just a reminder. You probably have heard or learned a lot about HIV and AIDS in the past, but it was just a small unit for this class. So transmission, it can be through blood, semen, vaginal secretions, breast milk, but not urine, throw up, toilet seats, tears, saliva, sputum, feces, sweat, or respiratory droplets. So there's a lot of misconceptions about HIV and AIDS, and a lot of ways that you can like be like culturally or whatever incompetent when caring with someone with HIV and AIDS. Obviously, like you want to be careful and don the proper precautions, but you want to make sure to also provide compassionate care and don't perpetuate HIV misconceptions. And an example of this is like wearing gloves while charting. Obviously, like you're not coming in contact with this patient, you don't need to wear gloves, but also just understanding how it could be transmitted and how it won't be transmitted. Okay, so it's an RNA virus. So eventually, like what that means is that it's integrated into the human genome, and so it copies that RNA sequence and it just gets perpetuated throughout the body. It destroys CD4 T cells, so the helper cells, and eventually, you know that this, you know how the disease is progressing because of the number of CD4 T cells in the body. And so eventually when it reaches a very low level, you know that they have AIDS now. So we'll go over that just right now. So acute is the 2 to 4 weeks. It's often mistaken for the flu. And so it's not diagnosed as HIV and AIDS really in this stage because they don't really know anything. It's like seriously wrong. And then asymptomatic infection, this can last for many years. And the problem with this is that it's so dangerous because you still can pass on this disease mostly through sexual contact. And so if they're not getting checked up frequently for STDs, HIV, and stuff like that, it's really easy to transmit it. And then it turns into a symptomatic infection. So the T cell drops to about 200 to 500, the count in the body, viral load increases. And so the treatment is to try and maintain the number of T cells in the body and decrease the viral load. You're never going to cure HIV, but the medications are trying to decrease the viral load and increase the T cell number. It reaches AIDS when you have a CD4 level of less than 200. And the main cause of death for somebody with AIDS is what's called opportunistic diseases. One of the most common being pneumocystitis. I don't know how to say this. GeroVC. I don't know. PCP is the abbreviation. This is a bacteria basically that's found within our bodies normally, but when you have such a low immune system, they're immunocompromised. They're these normal bacteria are going to affect the patient and cause disease. There's also Kaposi sarcoma, which you can see up here. And so this usually ends up killing an advanced AIDS patient because of a weak immune system, just one of these opportunistic diseases. Like I said, treatment, the goal is to decrease the viral load. So they need a combination of 3 or more drugs because resistance is easy to like come by. So like the drugs can cause resistance, like the HIV can become resistant to the drugs. And so having 3 or more drugs helps reduce that resistance. And then a reminder, something that I didn't know until last semester, but any immunocompromised patient, when they get a TB test, like the skin test, they're going to have a positive test at 5 millimeters or more, when normally like a non-immunocompromised patient will have a positive result at 10 millimeters or more. And then another thing is when you're immunocompromised and don't have like the ability to fight off live viruses. You can't get any live vaccines. So, like the nasal flu vaccine, like the spray, that's a live vaccine. They can't receive that. Okay, can make them super sick. Okay, so taking a manual white blood cell count. So they take basically 100 cells and they look at the percent of cells that are this kind or this kind or this kind. And so neutrophils, these are like the main guy in the body that does, like, they're the first responder to any invasion by a pathogen. So it makes up about 55 to 70% of those 100 cells. Lymphocytes right here, it could be T or B lymphocytes, 20 to 35%. They make up the antibodies and memory cells. And when you have a virus, lymphocytes are the higher number. Okay. Monocytes, 3 to 8%. They're in charge of phagocytosis. So they take in that cell and destroy it. You see these more long-term chronic infections. Okay. Sorry, my allergies are going crazy. So if I sound stuffed up, that's why. And then eosinophils, 1 to 3%. You see these in like parasitic infections and allergic reactions. Basophils, less than 1%. They're in charge of releasing the histamine, in charge of inflammatory mediators. Okay, and the common phrase that we've heard is shift to the left, and that means there's a high number of neutrophils, indicates infection. So basically, like, there's so many neutrophils that the bands, like, out of the 100 cells, it's basically like when you look at them under a microscope. This is where this phrase comes from. There's like a shift to the left. I don't understand all of it behind it, but that's what it's talking about. Band crisis means there's a ton of immature neutrophils, and if they're immature, they don't have the capabilities of fighting the infection yet, which is obviously not great for the body. So shift to the left and by band crisis. So both of these together, higher risk of sepsis. Okay. And so just generally understand like what each one of these is. You don't really need to understand the percentages except for that neutrophils is the most abundant of them all. Definitely understanding shift to the left, band crisis. Yeah. Okay. Okay, just quickly going over DIC. This is something that can happen under MODS, so multiple organ dysfunction syndrome, or from another underlying cause. And so, yeah, so it occurs from an underlying condition. So it doesn't just occur on its own. Something else is happening in the body to cause DIC. So it's a bleeding and thrombolytic disorder. So it's basically abnormal clotting. It's using up all the thrombocytes or the platelets to clot, which leaves the rest of the body without any clotting factors, which leads to hemorrhage. So it's this really complex thing where there's tons of clots in the body, which can cause issues with like perfusion. And then there's hemorrhaging in the body. Okay, so it can be caused by intrinsic or extrinsic factors. So intrinsically, it would be caused by like damage to the blood, like a transfusion reaction, sepsis, which is the common cause of MODS, which is also and causes DIC, sickle cell anemia, which is more common in African Americans, ARDS, malignant hypothermia, so reaction to anesthesia. Extrinsically, it can be a tissue injury, so extensive surgery, crash injuries, malignancies, neurological damage, endotoxins, or obstetrical conditions like pregnancy or birth. So in the labs, you're going to see decreased fibrinogen, which is a clotting factor, decreased platelets, increased PT, PTT, meaning it's taking longer for the blood to clot, and a high D-dimer. D-dimer just indicates if there's clots in the blood. Occult blood, you'll see because they're hemorrhaging, it's internal, not seen. Signs and symptoms of occult bleeds could be increased pain. Distended abdomen is a very common sign of this. Petechiae or ecchymosis, so bruising, and then the small pinpoint red dots. They're mottled, cold, so their perfusion is dropping. Their vital signs are going to change, probably a decrease in blood pressure and an increase in pulse. And then a positive guaiac test, so stool test, you'll find occult blood in the stool. Okay, so treatment is a heparin drip for the clots. Fluid boluses, you're going to give them blood products, fresh frozen plasma, platelets. You're going to treat the underlying cause. So if it's caused by like sepsis, try to treat the infection. And then hypovolemia, hypotension, hypoxia, acidosis. So you're going to be treating all of those things with DIC. Okay, An important thing to know, so you're giving them all these blood products, you're giving them, and like as a reminder, you give them like a bag of blood products. Their H&H, like their hemoglobin should, or their hematocrit should increase with every unit. A packet of blood cells should increase 3%. However, you're not going to see those changes for about 3 days. So, um, really, like the key indicators are going to be like your vital signs, perfusion, patient outcomes, stuff like that. Okay, so fluids, this is important. 1 kilogram is equal to 1 liter of water. So if someone loses 5 kilograms after dialysis, they've lost 5 liters of fluids. And so that's why weighing is really important when it comes to fluid balance, because we can determine how much fluid that they've lost or gained based on their weight. Okay, so movement of fluids, we have osmosis, water from a high to low concentration, specifically water, and then simple diffusion is a substance from high to low. Facilitated diffusion is using a carrier to move from high to low. You don't need any energy, but active transport requires energy or ATP to transport things from a low to high. So like the sodium potassium pump is an active transport pump, requires energy to um, switch them against their gradient. Okay. So then we have pressures. We have oncotic pressure, which is albumin, and so pulls water back into the vessels. And so when we don't have a lot of albumin and we're losing that protein, that's why edema can happen, because the albumin is not pulling that fluid back into the vessels. It's allowing it to leak into interstitial spaces. Hydrostatic pressure is our blood pressure. Osmolarity, just the definition is water balance in volume, the volume of it. Osmolality is it measures water balance in mass. And so it's really hard to tell the difference between the two, but it's important to understand them further. And so if you need to look up like a video to understand these pressures and the movement throughout the body, that would be important. But osmolality describes things like isotonic, hypotonic, hypertonic. Isotonic is plasma concentration. Things like your Na, like your sodium, or sorry, your normal saline that you would give someone is an isotonic fluid because it matches the concentrations of plasma. Hypotonic has solutes lower than plasma. And so what's going to happen is that water movement is going to happen. And because there's a lower amount of solute, it's going to suck water into the cell to try and equalize the solute water concentrations. So hypotonic is going to cause the cells to swell. And then hypertonic has a higher concentration than plasma, causes cells to shrink. So it's going to pull the water out to try and dilute how many solutes are outside of the cell. And there's situations where you would want a hypotonic or a hypertonic fluid, and we'll get into that in just a second. But the concentration, so intracellular fluid and extracellular fluid, there's about 2/3 intracellular fluid and 1/3 extracellular fluid. And the extracellular is made up of interstitial fluid, plasma, transcellular, so like cerebral spinal fluid, the GI, joint, pleural, and pericardium spaces. Okay. And this is just a picture showing like the blood flow, hydrostatic pressures coming out, osmotic pressures coming in. And this is the interaction between the like capillaries and the interstitial fluid. So always an exchange going on there. Okay, so fluid spacing. We learned about edema throughout the whole nursing program, but now we just have a name to it. So first spacing is normal. So it's between the intercellular fluid and the extracellular fluid. It's just a good normal exchange. And then the second spacing is interstitial fluid accumulates. And so this is edema right here. And obviously this would be pitting edema. It's graded on a 1+ to 4+ scale. And this is because, like I said earlier, like the albumin usually is the causative factor, and there's less albumin, so that means that water is not being pulled into the intracellular space; it's going into the extracellular spaces, causing that edema. And then third spacing is things like ascites right here. Accumulates in the part of the body, cannot easily be exchanged with the rest of the extracellular fluid. So what's basically happening here is this water is being trapped in a space that we can't reach. So giving diuretics may help, but really this water needs, like this fluid is usually taken out by like a centesis. So like this would be like a paracentesis, I think, but just taking away that fluid from the abdomen because we can't reach it with any of the normal measures. Okay, so this can happen. Third spacing can happen a lot with burns. Blisters is an example of third spacing, ascites, peritonitis, and pancreatitis. Okay. This is just a reminder of the angiotensinogen cycle. It's important for like the medications like ACE inhibitors or things like that. And this also has to do with water retention. And so coming from the liver, we have angiotensinogen, a protein. And then from the kidney, renin comes in and breaks up angiotensinogen into angiotensin 1. And then from the lungs, we have the ACE inhibitors that come, or sorry, the ACE enzyme or whatever that comes and breaks angiotensin 1 into angiotensin 2. And then that goes and it causes vasoconstriction of the vessels, which increases blood pressure, retains water, and then also signals to the adrenal glands to release aldosterone, which retains sodium and water because sodium and water follows sodium. And so it causes reabsorption of sodium chloride and water, which also increases the blood pressure and just retains water. So whenever you retain sodium, just remember that potassium is excreted. And so if this system is going into high drive and we're excreting potassium and keeping sodium, we could have a problem with hypokalemia and as well as cardiac dysrhythmias. Okay. Okay, so antidiuretic hormone is another factor or hormone that influences fluid balance. And so this is coming from our pituitary gland, which is signaled from the hypothalamus. Because in the hypothalamus, there's osmoreceptors. And so there's like when the blood osmotic pressure increases or decreases based on fluid balance, the hypothalamus receives that input and then tells the pituitary gland how much ADH to release or not to release. And so this could, so if they're like low on water or whatever, signals like more thirst to increase our blood pressure and maintain that balance. But the ADH also has an effect on the collecting duct of the nephron in the kidney. And more ADH will mean more water reabsorbed to prevent further dehydration. And just so you know, ADH is also known as vasopressin, which when we talked about shock, vasopressin can be given to also try and retain the water after like fluids have been given. And like in sepsis, for example, they give vasopressin to try and retain that water and increase the blood pressure and perfusion in the body. Okay. So insensible water loss is water loss that we can't measure. And so basically like our intake, we have like metabolism is 10%, food 30%. We can't really measure the water in food, but it's estimated to be about 30%. Liquids, 60%. You can measure liquids. And so just know that like when you're measuring intake, it's only 60% of our full intake of water because the rest of it is coming from metabolism and food that we can't measure. Output, feces, 4%, can't really measure the water content of feces. Sweat, 8%, we're not going to collect every droplet of sweat and measure it. Insensible losses are like sweating, breathing, like we exhale, like when you're in the cold weather and you see your breath, it's because of those water droplets coming out when you exhale. So, and the insensible output is, or water loss through output is really high in burn and fever patients because they're sweating a lot, they have tachypnea, breathing a lot. So it's about 28% of insensible losses through output. Urine, 60% measurable. So again, only 60% of full output is measurable. But it's nice because the urine right here, 60%, and liquids, 60% are equal. And so fluid balance, we want it to be equal. We don't want it to be too much or too little coming out. Or yeah. And so we want to do good INO reports. Foley, if you need exact measurements of urine, Foley is going to give you those exact measurements. Hourly measurements required if you need a strict INO. Okay. Okay, electrolyte imbalances. This is sort of the annoying memorization part, but you do need to know this for the HESI, for exams, for nursing practice. So when you think sodium, think neurological stuff. So we know 135 to 145 is our sodium. range. If you have a hypernatremia, just think big and bloated. Oh, and one other thing, that video that they have in Attend Class, the YouTube video, is really, really helpful for memorization of these electrolytes. Okay, but hyper, big and bloated, excess salt intake or decreased water intake, meaning the less water you have, the more concentrated sodium it is in your plasma blood, or excess water loss, diabetes insipidus, Cushing's disease, diabetes. Okay, so big and bloated, signs and symptoms, flushed skin, edema, low fever, polydipsia, so need to drink a lot to try and dilute that sodium. A swollen tongue is a late sign of hypernatremia. Change in mental status is a big one. So again, neurological changes. So treatment is increased fluids if they were lost. And so like in cases of diabetes insipidus, decrease water intake, so we're going to increase fluids. Or if the fluids are fine, the fluids aren't the problem, we're going to dilute the sodium. That's why we give fluids. We're going to put them on seizure precautions again because sodium, neurological issues, seizure precautions like patting on the side rails, suction near the bed. And then we also want to make sure to lower, and this goes for all electrolytes, if you're increasing them or lowering them, we want to do it slowly to avoid complications with the system that electrolyte most influences. Okay. Sometimes there will be like cultural questions related to sodium, like somebody from like Asia eats a lot of homemade soups or ramen, and they have a lot of hidden sodium. And so we want to educate and respect culture, but also recognize foods that have like that hidden sodium, or the cultural foods that have that sodium in them. Okay. And then hyponatremia, think depressed and deflated. So it can be from like SiADH, so it's like excreting a ton of ADH and not retaining that water. And again, sodium and water go together, so it's all flushed out. Or cirrhosis. Signs and symptoms: tachycardia, weak respiratory arrest. Treatment is decrease of fluids if they're in excess, and diluting sodium. And so if you have a ton of fluid, the sodium is going to show up as less because it's diluted. You can give 3% saline in emergency situations. However, it's not common because it's very dangerous, because it can increase your intracranial pressure, because if it's a hypertonic solution, which will be talked about later. But vasopressor antagonists, so like the medications that end in Baptin, seizure precautions, and again, not too fast. You don't want to change the electrolyte balance too quickly. So also remember, if a patient is in good health, they're asymptomatic, they had good labs the day previous, but now there's like a really abnormal event, or result in the labs, you want to question the lab before you question like your physical assessments and how the patient is appearing. And so you want to redo the lab before jumping to a conclusion like, oh my gosh, your sodium is 185, like what's going on? You know, that's just an extreme example. But hemolysis is the most common reason for labs being skewed. So like the blood products break apart when they're taken into the tube, whether they're being taken in too fast or the, sorry, I just cannot think of words today, but the tourniquet is left on for too long. It can cause blood to break apart and skew the results. Potassium, this is one that we know and love, 3.5 to 5.0. We want to do a full cardiac assessment when we have a potassium imbalance. Hyper, just think tight and contracted, can be from acidotic situations, catabolism. So cells have potassium inside of them. And so when cells break apart, they release potassium. And so things like burns or tumor lysis, things like that break apart all the cells and release a ton of potassium, causing hyperkalemia. Blood pressure meds, Addison's disease, things like that. Signs and symptoms, you're going to get ST elevation. Peak to T waves is like the most common sign that you're going to see. Going to be hypotensive, bradycardic. Their GI is tight, and so they're having diarrhea and hyperactive sounds. Neurotight, so they have a high deep tendon reflexes, so they're super flexive. And it can cause paralysis. Then the treatment, I saw this on TikTok once on a nursing TikTok, and I loved it. I thought it was so helpful. But I won't say it out loud, but DICK is the acronym you're going to remember for the treatment of hyperkalemia. So the first one, and it's in that order too. So the first thing you're going to give is dextrose 5% on a drip. And this is to make sure blood sugars don't drop when you give them insulin drip. And insulin, when you give insulin, helps when it helps bring sugars into the cells, but also helps bring potassium into the cells. So dextrose 5%, insulin, and then calcium chloride or gluconate. And this isn't to treat the hyperkalemia, but this is to stabilize the heart so that the hyperkalemia doesn't have an effect on the heart. Okay. And then K-oxalate is also known as sodium polystyrene sulfonate. This is going to bind the potassium in the bowels and cause massive diarrhea and output, which is how we know that it's working. And so DICK is the treatment for hyperkalemia. Okay. Oftentimes these patients need, if it's severe, need dialysis and obviously continuous ECG monitoring. Hypokalemia, just think low and slow, can be from vomiting, diarrhea, excessive suctioning, diuretics. So furosemide is a potassium wasting diuretic, and as well as insulin. So we just talked about, insulin brings potassium into the cells and leaves it unavailable for use in the plasma throughout the body. Okay. Signs and symptoms would be a flat T wave instead of peaked, ST depression, and a U wave. So just that extra wave after the T wave. Decreased deep tendon reflexes, remember low and slow. They're going to be flaccid, hypoactive bowel sounds instead of hyperactive. They're going to be constipated and instead of having diarrhea. And this can lead to paralytic ileus. Okay. Treatment would be potassium supplements, could be IV or oral, potassium foods, like squash, tomatoes, bananas, beans, avocado, kiwi, dairy, dark leafy greens. You will want to memorize some of those high potassium foods just in case you want to restrict potassium for a patient or increase potassium intake. Important is to not ever give any potassium boluses. You're never pushing potassium, and as well as with potassium that is in a bag, so a sodium chloride infusion with 20 milliequivalents of potassium. We want to make sure that the bag, if you ever have to inject potassium into a bag, that it's well mixed, because we don't want to give one part of the fluid has more potassium than the other part, and that could bolus potassium and cause stop the heart, And so the bag is thoroughly mixed, and the rate should never exceed 10 milliequivalents per hour. And so you just have to do the math on that and make sure they're not getting more than 10. And you're always checking the IV site frequently because of the risk of phlebitis and tissue damage there. This is super, super important, so remember that. And then another reminder is that digoxin therapy, hypokalemia can increase the availability of digoxin in the blood, and so it increases the chance of having digoxin toxicity. And remember that the first sign of that is nausea, vomiting. Okay. Potassium will always be one of those important ones that you're going to be tested on. So probably sodium. Sodium's another one too, I would say. Chloride, just remember that sodium and chloride are like BFFs. They go together. And so chloride is going to follow sodium, and it does the same thing. And the range is 96 to 106. Okay, so hyper, same as sodium, all the signs and symptoms and causes. Hypo, all the same signs and symptoms, except another one for chloride specifically is a fever. Okay. Magnesium, this is one that the video really helped me with to understand. And it's basically the analogy of magnesium is the sheriff in town. And so it controls the heart, uterus, and deep tendon reflexes. And the range is about 1.3 to 2.1. So it's pretty narrow range. But hypermagnesium, or magnesia, or whatever, the sheriff is in town. Okay, so they're really regulated. So everything's super calm and quiet because nothing's going out of control because the sheriff's on top of it. Okay, so everything just slows down. And this can be from renal failure, hypothyroidism. Signs and symptoms, you get heart blocks, so prolonged PR intervals, bradycardia, again, everything's slowing down, hypotension, low deep tendon reflexes or not really responsive, shallow breathing, hypoactive bowels. So everything has just slowed. Okay. Treatment is avoid foods like green veggies, nuts, bananas, peanut butter, chocolate. Those are all high magnesium foods. Increase fluids to try and dilute that magnesium. Diuretics to try and just waste the magnesium. Dialysis to take it out manually. Calcium gluconate, again, is to protect the heart from lethal dysrhythmias. Okay. It says too much. DTR is very reduced bradycardic, bradypnea, decreased loss of consciousness. And so the so calcium gluconate is the antidote basically for giving too much magnesium. And that's something important that you'll learn in like maternal as well, because magnesium is a drug that they give to control hypertension or preeclamptic patients to prevent them from having a seizure. But if it's too much, like their deep tendon reflexes are super reduced, they have bradycardia, bradypnea, loss of like their level of consciousness is changing, calcium gluconate is the antidote. Okay, so a hypomagnesium, the sheriff is gone, so everything goes wild. Okay, and so it can be from GI losses, chronic alcoholism, or malnutrition are probably the most common causes of hypomagnesium. Hyperglycemia or like PPI medications. Signs and symptoms for SODS de Plantes or points, VFib, tachycardia, ST depression, T inversion, high deep tendon reflexes, nystagmus, so like the eye twitching, diarrhea, and seizures. So like I said, everything's just gone crazy. Treatment, supplement, IV magnesium sulfate, but we're watching for hypotension, cardiac or respiratory distress, and seizure precautions. Okay. Calcium, just know it controls the blood, bones, and beats. So the 3 Bs. 9 to 10.5 is the range. Hypercalcemia, swollen and slow, so the moans, groans, and stones. So it can be caused by hyperparathyroidism, thiazide medications, thyrotoxicosis, and acidosis. Signs and symptoms, so everything's slow, so constipation, bone pain, slow deep tendon reflexes, severe muscle weakness, stones, because calcium can create renal calculi, and so like kidney stones, increased fracture risk, and so the calcium is in the blood, not the bones, which means that pathological fractures can occur. And then dysrhythmias, because it controls the heart as well, the beats. Okay, treatment, weight-bearing activity that can help increase the uptake of calcium into the bones, increase fluids to dilute it, acidic drinks to decrease stone formation, so like cranberry juice, IV fluids, biphosphonate, decreases osteoclast action. So osteoclast is what breaking apart the bone and releasing calcium into the blood. This is a common treatment for people with osteoporosis. An important thing about biphosphonate is that you need to take it with a full glass of water and instruct the patient to sit upright for 30 minutes, at least, okay? And then calcitonin increases renal calcium excretion, and then dialysis as like sort of like a last resort. And then hypocalcemia, this is very common if you had like a patient who had their thyroid taken out or a neck surgery, because the parathyroid glands that control calcium uptake or release is right behind the thyroid, and it can be accidentally damaged during like taking the thyroid out. And so we want to watch for signs of hypocalcemia. Also with chronic alcoholism or malnutrition, going along with the hypomagnesium, okay? The 2 important signs to remember is Giselles. And so when you inflate the blood pressure cuff, the hand's going to like flex like that. That's a sign of hypocalcemia. Javostex is you stroke the face and it twitches, okay? They also have diarrhea and a circumoral tingles. Circumoral right here is tingling around the mouth, okay? Treatment is calcium or vitamin D foods. Vitamin D helps the uptake of calcium in the gut. IV calcium gluconate, paper bag breathing, helps tetany and stops respiratory alkalosis, which can cause hypocalcemia, and create a more acidic environment, which decreases calcium in the blood. Okay. I think I meant to say 40 here, but 40 to 45% of calcium is bound to albumin. So low albumin may result in falsely low calcium. Okay, so that's just important to know with your labs. And then we have phosphate, which is calcium's enemy. They work inversely, has almost the same range as potassium. So a hyperphosphatemia could be from renal failure, rhabdomyolysis, so like they break apart of muscle, sickle cell anemia, hyperthermia. Signs and symptoms, basically the signs and symptoms of low calcium is the signs and symptoms of hyperphosphatemia. The treatment would be to restrict dairy. Dairy is high in phosphates. Calcium carbonate binds phosphate, hemodialysis, and then you're going to correct hypocalcemia because inverse relationship. And so when you have hypophosphatemia, it's likely you're going to have hypercalcemia. Can be caused from malabsorption, chronic diarrhea, malnutrition, chronic alcoholism, diabetic ketoacidosis, respiratory alkalosis, so that alkalytic state. So yeah, signs and symptoms of hypercalcemia, treatment, increased dairy, IV sodium phosphate, or potassium phosphate. Okay. So lots of electrolytes, lots of stuff. Just make sure you know, especially the ranges, the treatments for it, the signs and symptoms are really important, and then some foods that deal with each electrolyte. Okay. Acid-base imbalances. So the orientation PowerPoint on acid-base imbalances would be a good one to review. General rule, acidosis, the CNS is depressed. So you're gonna have a headache, you're lethargic, weak, confused, and the respiratory is going to compensate by trying to breathe faster to get that CO2 out and decrease the acidosis in the body. Alkalosis, you're gonna have symptoms from like electrolyte disruption. So like hypocalcemia, muscle cramps, CNS excitability, you're tingly, numb, you have tetany. And so those are like the general rules for like signs and symptoms you're going to see for acidotic states or alkalic states. Okay. Another important thing is to remember that respiratory regulation is much quicker than renal. However, renal has longer lasting effects. So this buffer system right here is just a good one to remember. Is that like CO2 and water combine to make carbonic acid. And those break apart to be hydrogen ions, which control the acidosis in the body, and then bicarbonate, which is the alkalosis, basically. Okay. And so you just want to understand this carbonic acid bicarbonate system. So like if you breathe more, you're releasing more CO2. You have less carbonic acid, meaning you have less hydrogen ions, so decreasing acidosis. Okay. Okay, fluid imbalances, going back to fluids, we have a fluid volume excess. This could be like a postoperative complication. Surgery induces a stress response, which means more ADH is going to be released, as well as aldosterone, which retains sodium and water, as well as during surgery, many fluid boluses are given. And so we want to be watching for signs and symptoms of excess after surgery. And if they have an excess, we want to restrict dietary sodium because sodium and water are friends. The more sodium you have, more water you retain, become big and bloated. Okay. Fluid volume deficit. It's common to have orthostatic hypotension with this. As a reminder from physical assessment, check by lying supine, pulse and BP, then sitting, then standing, waiting a couple minutes in between each. They get dizzy or short of breath while walking. You're going to want to sit them down as soon as possible to make sure they don't fall, basically. Okay. They may need replacement fluids at a wide open rate. Wide open rate basically means like the roller clamp, you don't attach it to a pump, you just open it wide and let the fluid run in as fast as they can. That's mostly done in the ER. Severe deficits need IV replacement. Like while mild, you want to stick with like PO, like keep the gut involved in the fluid replacement and fluid balance. Okay. Okay, so as far as like fluid bags go, on the bag, like in the big long paragraph that's on the front of it that none of us ever read, they actually have some cool information. You can see the osmolarity, whatever, milliosmol concentration. So for isotonic, you're going to want in between 250 to 375, and it's going to be on the bag, and it will say that, and that's because this is the milliosmols that are in our plasma. Okay. So isotonic fluids are good for normal fluid replacements or emergencies. They're not good for like fluid overload or heart failure, hypernatremia, or hyperchloremia. Just because these isotonics fluids are just going to increase the volume in our vessels, which will hurt all of these things going on right here. Okay. So examples of isotonic fluids are like normal saline, lactated ringers, and D5W, which actually becomes hypotonic after dextrose is used. So you want to keep that in mind. Okay, but those are all the milliosmol amounts there. Just remember that normal saline is the only product that, or the only fluid that can be given with blood products, and that blood products in this normal saline will be running into its own dedicated IV site. It won't be combined with any other medications. Lactated ringers has like potassium, lactate, and calcium, common to give like with surgery, after surgery. However, with sepsis, again, we don't want to use lactate products because there's already a high amount of lactate in the blood. Or if they have renal or liver failure, we don't want to be using lactated ringers. Okay. Hypertonic is more than 375 milliosmoles. So this is really interesting. So hypertonic can be used to decrease intracranial pressure or treat shock by pulling fluids out of the cells and into the vasculature. And so basically like intracranial pressure, there's too much space being taken up in the brain, and these hypertonic fluids are going to pull some of that fluid out of the cells and just into circulation, meaning that it takes up less space in the brain and thus decreases intracranial pressure. Okay. Also with shock, it pulls fluids back into the vasculature and to increase the blood pressure. Okay. However, with hypertonic fluids, you want to carefully monitor for pulmonary edema. So signs and symptoms like crackles, increased pulmonary vascular resistance, coughing up blood, orthopnea, shortness of breath, things like that. Examples of this could be D5NS, D5 half NS, or D5LR. Okay. Hypotonic, less than 250 milliosmoles, can be used for DKA or hyperosmolar hyperglycemia syndrome for type 2 diabetic patients to increase intravascular volume and push fluids into cells. Okay, so an example of that could be half NS, so hypotonic fluids. Okay. A colloid is things like a plasma expander, so you give like albumin. So albumin would increase the plasma because it pulls fluids back into the vasculature instead of having it go to the interstitial spaces and form like edema. Okay. Central venous access devices, just a quick recap. There's a high risk of infection, so try to access the ports as little as possible and use aseptic technique, making sure to recap the ends with those antiseptic caps that they have. Masks on when changing the dressing. If you feel resistance, do not keep pushing because you can dislodge like an air embolism into the heart and the pulmonary circulation, which would not be good. So a lot of people when flushing the CVADs use like a push pause technique. So you push a little, pause, push, 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 to prevent like slamming that full 10 milliliter syringe into the CVAD and risk dislodging a pulmonary or like a air embolism. Okay. So if this happens and you suspect that air has been pushed into your patient, which goes straight to the heart, you want to lower the bed into Trendelenburg. So this is the head, Trendelenburg, and place the patient on their left side to prevent air from entering the circulation, like pulmonary circulation. And then obviously like put oxygen on, call the provider, stuff like that. Okay. Just a review for labs. This is, like I said, this has like a ton of stuff in this one presentation, but A1C is diabetic control over 3 months. So somebody can't like fake their blood sugars by like fasting before they get their blood sugars taken. Should be less than 7% for diabetics. Over 9% indicates poor control of their diabetes. Okay. Troponin and CKMB mean cardiac damage. They had a heart attack. BNP is high with heart failure. And then urinalysis, the color you want to look at. Some antibiotics turn it blue. Some drugs turn it orange, like bile, or what's that one drug? It's like a TB drug. Rifampin or something can cause orange urine. You want to look at the clarity of it. Specific gravity is 1.005 to 1.030. The higher your specific gravity is, the more dehydrated you are, or like had a vomit, diarrhea incidents. pH should be between 4.6 to 8.0. Should be negative for glucose, negative for ketones, less than 2 for red blood cells, 0 to 8 for proteins, and negative for bilirubin and bacteria. Okay. This is just good to review. Just these have all the levels. And again, some of these are a little different than the ones you learn in class. But when you get a question asking you like to know like the normals of lab values, it's going to be way out of range, way out of normal, because these labs can vary based on institution, standards, stuff like that. Okay. Okay, practice questions. Just pause it like always, and then we'll go over it. Okay, so nurse is preparing to care for a client with a potassium deficit. The nurse reviews the client record and determines the client was at risk for developing the potassium deficit because of what situation. B, requires nasogastric suction. So potassium-rich GI fluids are lost through GI suction. They place the client at high risk for hypokalemia. Any client with tissue damage, like A, C, or D, those are going to be at risk for hyperkalemia. Okay, because remember, tissue has a lot of potassium, and if it's broken apart, potassium is released into the blood, causing hyperkalemia. Okay. Next question. Okay, so this client has a pheochromocytoma, which is a tumor on the kidneys. And they've been experiencing clinical manifestations of hypermagnesemia. When evaluating the client, the nurse should determine the client's status is returning to normal if which is no longer exhibited. Okay, so the answer is C, areflexia. So remember, magnesium is a sheriff, and when he is in town, it's calm and quiet. So high magnesium slows everything down, including reflexes. So we want to make sure that areflexia is no longer exhibited. So we want reflexes to return as a sign that hypermagnesemia is being resolved. Okay, and the rest of these is a sign and symptom of hypomagnesemia. Okay, so an assessment of a newly admitted client, the client's heart rate is 110, so tachycardic, blood pressure shows orthostatic changes when he stands up. His tongue has a sticky paste-like coating. The client's spouse tells the nurse he seems a little confused and unsteady. Based on these assessments, the nurse suspects that the client has which condition? And the answer is A, dehydration. So the heart rate increases with dehydration to try and maintain their blood pressure because there's not as much fluid in the vessels. Blood pressure reflects orthostatic changes caused by reduced blood volume. When the client stands, may experience dizziness because of insufficient blood flow to the brain. Alterations in mental status can occur, especially with elderly clients. But we don't know the age of this patient, but oral mucous membranes, usually moist, are dry and may be covered with a thick pasty coating. Dehydration. Okay. Okay, so they have a dehydration diagnosis. The client's receiving IV fluid, which assessment data would indicate that the dehydration remains unresolved. Okay, so we have a urine-specific gravity of 1.043, which is higher than the upper limit of 1.030. The higher it is, the more dehydrated you are. Okay. Okay, they have heart failure. The client is dyspneic and has crackles. Which additional signs would they expect if they have excess fluid volume? And the answer is C, an increase in blood pressure because there's more fluid in the vessels, increasing blood pressure. A, weight loss. It would be weight gain if we had a fluid volume overload. Flat neck and hand veins, they would be full. And then CVP. So this is when so like hemodynamic monitoring and fluid balance and all that go hand in hand because CVP is just measuring the fluid volume of the body, okay, in the atrium, the preload. Okay, so CVP would be increased with fluid volume overload. Okay, so this is when you're just tying in the previous lessons you learned to the current lessons, and that's why your tests are like very comprehensive, taking in things from like first unit exam, second unit exam, and tying your knowledge all together on like using CVP to determine fluid volume, as well as like tying in maybe sepsis, shock, stuff like that. So, okay. Okay, so they have hypocalcemia suspected. Which cardiovascular manifestation would they expect? And the cardiovascular manifestation is A, hypotension. B, increased heart rate. Well, with hypocalcemia, you'd have bradycardia because calcium helps contraction. If you don't have as much, the heart is not able to contract as much, which bradycardia and hypotension go together. The heart's not contracting as much, meaning the blood is not pumping through the body as efficiently. Cardiac output is less. Hypotension. So C, bounding peripheral pulses. We'd actually have weak pulses with hypocalcemia for that same reason of that bradycardia, less contraction of the heart. And then D, shortened QT interval on electrocardiography. You'd actually have prolonged QT interval because of that slower beating of the heart. Okay. So these ECG manifestations of these electrolyte imbalances are really difficult to understand, but I would say some of the most important ones are the changes when it comes to potassium with the heart and the ECG changes. Okay. All right. Okay, so you have a patient with severe burns. You notice his abdomen is growing larger with fluid, thinking ascites. Intake output are equal and weight has not changed. What do you suspect? Third spacing. So again, third spacing, that's the fluid we can't access. Intake and output are equal, so that's not affected. Weight is not changed, it's just outside of the tissue, okay? Okay, which patient is most at risk for a fluid and electrolyte imbalance? And the answer is A, an 8-month-old with a temperature of 2.8 and diarrhea. So they have two things that can cause insensible losses as well as just stark losses. And infants under 1 and older adults are the most at risk for fluid-related problems. Infants have the highest amount of total body fluid. So like 80% of their body is made up of fluid, which is crazy. So any imbalance of fluid is going to cause major effects on an infant's body. So yeah, that's the answer. Okay, and like the other answer you would be considering is maybe a healthy 87-year-old because they're older. Episodes of gout. Gout doesn't affect really the fluid electrolyte imbalance, but this 8-month-old has two situations here. Okay. Okay, so the CR patient is tachycardic, hypotensive. They have 25 mils per hour urine output, which is normal, should be about 30 mils per hour. Sodium level is 160. Remember, the range is 135 to 145. What do you expect to be made by the doctor? What order? The answer is B, administer hypertonic solution of 5% dextrose and half NS and monitor urine output. So half NS, we don't have as much sodium, so we're not giving them more sodium boluses, basically. And the dextrose solution will help rehydrate this patient because this patient seems to be fluid deficit and the sodium is high because their fluid is low. So it's like that. Because the fluid's low, it's just like the sodium is hypertonic, basically. Okay, let's look at the other answers. So A, restrict fluid intake and monitor daily rates. Well, the sodium is too high. We want to dilute the sodium, so we want to be giving fluids to dilute that sodium. Okay, blood pressure and urine output is just too low to just monitor. Okay, so like we're not at that point where it's like asymptomatic, where it's like, oh, like we can just monitor this patient. Like something needs to be done because of their vitals. Okay. C, administer hypotonic IV solution and administer sodium tablets. Well, sodium's too high. We don't want to give more sodium. They're at a seizure risk already. Okay. D, no interventions needed. A do nothing answer is no bueno. Okay. So B is the best option here. Okay, so we have potassium chloride intravenously prescribed. Which action should we take to prepare and administer potassium? So A, get a IV pump. We don't ever want to be monitoring just based on like the roller clamp. Monitor urine output during administration. So if at any point the urine output becomes too low, we know that the kidneys are at risk for having an AKI. And so we want to talk to the doctor about what to do about the potassium infusion. Okay. C is not correct because we never bolus potassium. D, monitor for infiltration or phlebitis. Potassium can have that effect on the IV site. E, ensure that the medication is diluted in the appropriate amount of fluid. Great. Ensure that the bag is labeled so that it reads the volume of potassium in the solution. So these are all safety measures taken to administer potassium intravenously. Okay, taking care of someone who is taking furosemide and digoxin. We know furosemide is potassium waster, and hypokalemia can cause higher amounts of digoxin, in the blood, which can cause toxicity quicker. Client's potassium is 2.5, obviously too low. Which additional assessment will the nurse make? So A, heart rate. Hypokalemia increases effects of digoxin, make it toxic faster and could cause bradycardia. Okay. Because the whole point of digoxin is to increase the contractility of the heart, but decrease the amount of times it has to beat per minute. Okay. So the heart rate starts to go lower and lower and lower. We know that digoxin is too high in the blood. Okay. Okay, so they're assessing a client with a sodium level of 118, which activity takes priority. So sodium is too low. So instruct the client not to ambulate without assistance. And so because it has neurological effects, hypo or hypernatremia, we want to make sure that they are on seizure precautions as well as ambulation precautions. They're high fall risk. And so safety first can cause muscle weakness because the sodium is what our muscles use to depolarize and cause action potential and contractions. And so we don't have enough sodium. It's not doing that in the body. So, yeah. Okay. So which client does the RN assess first? Priority. The answer is C, someone receiving IV diuretics whose blood pressure is 88/52. Sorry. So someone with hypotension may have developed hyperperfusion caused by hypovolemia, lots of hypos, but immediate interventions are needed. They're getting these IV diuretics. They probably need to stop getting the diuretic because the fluid is just wasting out and they don't have enough to maintain a normal blood pressure and normal perfusion in the body. Okay. Looking at the other ones, a client with nausea and vomiting complains of abdominal cramps. Well, it's probably expected. Abdominal cramps with nausea and vomiting. NG2, who has dry oral mucosa and is complaining of thirst, we would want to address that, but not a priority. D, a client with normal saline infusing at 150, whose hourly output has been averaging at 75. It's pretty, might be a little high, but like we would want to assess them for fluid overload, but 150 is not nearly like a high enough rate to like cause significant problems usually in people. Okay. Okay, so I have a serum potassium level of 6.9. What did the nurse implement first? So the first thing is like safety. We want to assess first. And so we place them on a cardiac monitor because we know that potassium has effects on the heart. So the other ones are all things that you would do. And this is just classic nursing question, but just the first thing we do is assess, make sure their EKG is okay. All right. Okay, so 72-year-old, again, elderly patients are way at risk for fluid imbalances. They have a history of dehydration. What does the nurse delegate? So they delegate offer fluids to drink every hour. That's something that a UAP can do. Assess, well, we don't delegate assessments. B, choose appropriate fluids. That's what the doctor does, so no. C, monitoring skin turgor. This is again assessment. So this is just going back to your basic delegation questions. Okay, so they have hypernatremia. What does the nurse do first? First is to encourage fluid intake. So we're going to go from least invasive to most invasive, right? C, restrict sodium, administer diuretics, and monitor. Like, yeah, you would want to monitor the serum osmolarity, but like if you could only do one thing before leaving the room to help with the hypernatremia, it would be to encourage fluid intake, especially for elderly adults. Okay. That is it. Sorry, that was sort of a doozy. This is one of the more complicated, I would say, topics just because of the memorization it requires. But as long as you can tie in all of what we just learned to your previous lessons, like fluids, your perfusion, your blood pressure, shock, respiratory situations with fluid overload, heart failure, cardiovascular stuff like that, you will be okay. It won't make up like the majority of like your test, but there will be questions thrown in about this. And so you're going to want to make sure you know it. But best of luck.